So Daryl, talk to us about using your best treatment up front. There's a lot of talk these days about should we be saving something? We know that DRD and DVD and KRD in second line are really great. Should we be saving the Revlimid backbone in order to get a better second line treatment? What are your thoughts on that?
I think it's a good question. I think that's on top of mind for a lot of people, particularly given the POLX result of 45 months of PFS in second line. I think the general principle, though, is to use your best agents up front. And the main reason that I think sticks with me is that there's a great deal of attrition in the number of patients that move from first line to second line. It's actually quite surprising how few, on the studies that have been done, how few patients actually get to second line, in the range of 50 to 60%. When your gut feeling would be that most patients get to second line, it seems it's not true from multiple trials, including a Canadian Alberta database that suggests the same. So I would tend to use whatever I think is the best combination up front, rather than try and reserve something for later.
I completely agree. The fact also toxicity. So same drug, if played used later, will give you much more toxicity, because again, we're talking about more frail patient that is a third, fourth line of therapy, and the same regimen can definitely cause more problems at that point. I completely agree. We have good drug, luckily for our patient. We should probably use them in the right setting up front, because maybe, as you said, is a patient will never get a second chance, will never get more passing the first line of therapy. So I completely agree.
Particularly in those elderly patients, I was intrigued, but that by those patients that were 70 and older, good chunk of those patients, it wasn't disease progression that kept them from getting second line. So you really wanted to take your best line first and give them the best chance that they have.
Mm-hmm. Yeah, I think for some older patients, it's living a natural life, really, and dying from other causes, rather than needing a second line of myeloma treatment.
Yeah, I agree completely. It's an uncomfortable position to be in, and I think has to do with the nature of how clinical trials are done. They're started in advanced disease and slowly moved up, and then we have the delay for funding. So I console myself that eventually we'll have Maya and we won't have to go through this. But I think that idea of saving something, which is attractive, I think, to a lot of community physicians, and I understand the dynamic, but switching gears a bit, when that was tried with stem cell transplant, you can see from the randomized trials very recently of early transplant or delayed to first relapse on the IFM trial and the Italian trial, that there were a large number of patients who missed the option for transplant in a younger population. It was surprisingly high, so they lost that benefit of high-dose melphalan, and I think that principle holds forth and it just supports why we don't feel comfortable doing that in elderly patients who are going to have even more comorbidities at the time of their first relapse. And I think this is comparing apples, oranges, and cantaloupes, but when you try to look at the benefit, presented at an abstract here is our data in transplant eligible in Canada using Cyborg-D, a transplant, and Revlimid maintenance, and we get 58 months from diagnosis, which is astounding in a real-world setting. I mean, the IFM 2009 trial got 50 months, not in a trial population. So in a sense, now you have to look at all sorts of factors. Is that 65 to 70 patient going to get 58 months, or do they fall off and only get 45? But still, I think we would have to consider the trade-off in quality of life, mortality, morbidity. But still, I would love transplants to go away.
I think we all would.
Yeah, it's a blunt instrument approach. It's really a blunt instrument approach, quite crude. But there's something about high-dose melphalan that we still need to tweak the non-transplant regimens to come up with that very long first remission. I do think you can delay these treatments and get the same survival, but I don't know if patients would agree, but getting that long first remission when they have the most benefit, least damage, feel the best, I think argues for considering that first and second PFS as well as the overall survival. Although I don't think the health economists would necessarily agree.